Good afternoon, everybody. Hi, my name is Gary Ludwig, and welcome to this afternoon's webinar. I'm honored to serve as President and Chair of the Board for the International Association of Fire Chiefs. This is our fifth webinar, and we will be conducting them every Monday at 4 p.m. Eastern Standard Time. I want to thank everyone who is joining us on this IAFC Corona Task Force webinar, either directly or later when you listen to the recording. We also want to thank all those who are contributing today, all our panelists. The IFC represents the leadership of over 1.2 million firefighters and over 30,000 fire departments in the United States. We also have members in Canada and other countries around the world. Our Coronavirus Task Force is chaired by Chief John Sinclair and has a large spectrum of experts on the task force that continue to push out timely information on the coronavirus, including using these webinars. The chair of our Economic Task Force is Steve Pegram. He'll be joining us today also. And the chair of our Best Practice and Lesson Learned Task Force is Chief Tom Jenkins, and he will also be joining us later on today. You'll hear also from Dr. Jim Augustine, our Government Affairs Director, Ken LaSala, and also Christina Baxter will also be talking to us about the impact of coronavirus and lessons that we can learn and take back to our departments. This audio is being broadcast using voice over internet protocol technology through your computer speakers or your headset. Please make sure your speakers or headsets are turned on and the volume is turned up. If you're having any difficulties and you're experiencing any difficulties of any type, please contact WebEx, and their support number is listed on the screen there at 866-229-3239. And lastly, if you have any questions about COVID-19 or information presented in this webinar, please feel free to email our task force at covid19tf@iafc.org. And also, do not forget, we have a resource webpage set up with a whole myriad of information available to you at iafc.org/COVID-19. Now I'm going to turn it over to my good friend, Jim Augustine, Dr. Jim Augustine, who serves on our Corona Task Force as our medical advisor and director. And Jim, you have the floor.
I have quite a bit of information to share with you this week around two very timely topics. One of them is our return to work and the problems that our members are facing doing that, and the second is about testing. So let's start with what's important, which is what we're learning about taking care of our members. I talked the last time about the problem with coronavirus, in that the presentation of symptoms is really very wide in this disease. That presentation problem leads us to really find it difficult training our fire EMS providers what the patient looks like who has coronavirus. What I mentioned last week, and I want to make clear of, is that in front of a patient who potentially has coronavirus, a very key assessment is done using the pulse oximeter. And I mentioned that that is the best monitor device for the patient for us to help determine how sick they are. It is not a good indicator of whether they're sick at all. And for that, our best instrument is the thermometer and a symptom check. So for our personnel who were evaluating at the fire station at the beginning of a shift or as they arrive for a call, the best way to find disease is to ask them if they're having any of the key symptoms, and then checking a temperature. For the patient who has an illness and is sick in front of us, and we're making a determination about where they need to go for care, the pulse oximeter is really key. I want you also to know that across the country, EMS leaders, medical directors are looking at our form of resuscitation and what patients we're going to forego resuscitation on. I expect in the next week you will hear, because on Friday the American Heart Association released new guidelines for resuscitation in the face of the coronavirus. Those include more compressions, less bagging, no mouth-to-mouth, and a termination of resuscitation position should the patient not be responding to treatment and therefore not likely to respond for transportation to the hospital. Next slide. The approach to resuscitation is then about no mouth-to-mouth, using a scout to go determine what the condition of the patient is, minimizing the spray that comes from the patient when we do any airway interventions, a critical decision about whether we're going to use intubation to maintain their airway or another form of an airway, and then rapid contribution of the medical control system to get us to termination of resuscitation when it is needed. Next slide. Our ongoing challenges then in resuscitation, this is the reference to the American Heart Association standards that were published last Friday and was a timely update for us. These should be discussed with your EMS leaders in your department and your medical directors. Next. Okay, again, for our people, our personnel, our staff, in the station common areas, a good idea to use masks, use a health monitoring form, and then checking on arrival for either a call or for shift. Are they having any of these critical symptoms and what their temperature is? Next slide. The CDC guidance on Thursday changed, and it now includes for essential workers, which fire EMS providers certainly are. It makes a recommendation that they no longer have to go into quarantine or isolation, that instead that surveillance check is done, and that for significant exposures, for the next 14 days, they do a symptom check and a temperature check twice a day, and that they wear a mask in order to prevent them from spreading disease to other people. So you should have this new CDC guidance available for your human resources person or for your occupational medicine provider to assist in determining back to work situations. Next slide. Okay, let's talk about testing. And a very important part of what we are developing in this country in response to this virus is a way of testing for it. To date, that testing is done sticking a swab into the nose or into the mouth, but preferentially in this country, it has been into the throat. What that swab does, it picks up materials in your nose or your throat, and then a test is done which looks for pieces of the virus. So that's called polymerase chain reaction testing, or PCR testing. And many versions of this now come with rapid answers, including what we're using in the Atlanta area, which is about a 15-minute test that is done, is available to our first responders through the Minute Clinic system. They go to a parking deck at Georgia Tech. They keep the windows up in their car. They go to the testing area. They swab their own nose and hand it off to the worker there. They park their car, and within 15 to 30 minutes, they're delivered the test result by phone. That is right now probably the gold standard of testing that is done for evidence of the virus in the patient. Next slide. All right, what is coming now is testing for antibodies. So that is looking for your body's reaction to something that is presented to it, like a coronavirus particle. If you want to think about it, little proteins circulating around in your system looking for bad stuff. And if they find it, those antibodies release a series of things to kill bad stuff. So that's what antibodies are. There are several versions of antibodies that have names like immunoglobulin M and immunoglobulin G. Those are two important ones. Currently, that is what testing is being designed around, is those two antibodies. Traditionally, IgM antibodies are formed first, and they form typically within 7 to 14 days of exposure to something that your body does not like. And then long term, you are protected from many of these things by the long-term immunoglobulin antibodies, which are the IgG antibodies. So a little science behind those names. Next, please. So what happens here in a diagram is that early on, your body's building a reaction, but does not necessarily have immunoglobulins built yet. At some point, let's say 4 to 5 days into an illness, you begin to form antibodies. The first ones are IgM antibodies, and then more slowly, typically are built the IgG antibodies that will give you long-term defenses against that particular bug. Next slide, please. Put together, then, you have a composite reaction that looks something like this. And this says if you do 2 forms of testing, testing for the virus itself and then testing for the immunoglobulins, you will be able to, we believe, find out whether someone has an acute infection, hasn't formed antibodies yet. They've begun to form antibodies, or they have formed long-term antibodies against the coronavirus. So that is how the testing sequence may work. As yet, we have no idea how long a period of time this stretches out, and the approximate times that are given on this slide give you some example that this takes place over days to weeks. Next slide. Then we look at this long-term sequencing of how to look for people with no symptoms, very mild symptoms, or with severe symptoms, and what their time course looks like. Now, what I have given you is the beginning of the science on this. As I will refer to, this is been called the Wild West of testing right now. As of this morning, there are 106 companies that have applied to the FDA to sell coronavirus testing products. The vast majority of them are doing antibody testing, and 106 companies have applied. There is 1 company that has been approved so far. The others are operating off of what's called an emergency use authorization. It is not FDA approval. Many of those 106 companies have looked for a business model, and one of the places that they can go and attempt to sell their tests is to fire, EMS, law enforcement, and other departments. What is very important to tell you is that almost none of these tests have been approved, and it will take some time before the FDA will approve them. Many of the state bodies have begun to take a look and said none of these are reputable enough in the antibodies testing space for us to give recommendations to. Hospitals have not recommended that form of testing yet. All of them are using what is FDA approved, which is the nasal tests that have been done for PCR. I urge you to keep in track with your medical director, and for your medical directors to stay in touch with the hospitals. The hospitals really have a much more important set of uses for these tests for their personnel who are exposed to patients, and they need to determine with, frankly, a smaller workforce how they can continue to work looking at the presence of the virus and the presence of immunity in their employees. If you'll stay in touch with them and garner recommendations from them, and as well the IAFC, the IAFF are looking at these at the national level and trying to provide timely recommendations. As of now, the correct words for this are, it is the Wild West, and at this point, we don't know how these tests will be sequenced together to give the information that we need about safe management of our personnel. We do know that if you have virus in your nose, you have some degree of infectiousness. Next slide. So we're in April, and I am thinking that 2 weeks from now, we will have much better ideas of when this testing will be reliable and which tests will give us better information. We believe that those tests will first be used in areas that have been our high priority early on communities. So that this is Seattle, California, New York. And then as other communities have come across this disease and had to deal with it in larger numbers, the use of that testing can spread using our best practices. April has been a long month already, and we're only 13 days in. Hopefully, we're going to get better answers about availability of PPE and its use, and then our ability to test in a timely manner, give our personnel the answers they need, get them back to work, or get them the care that they need. That's the end of my presentation, Chief Ludwig. Thanks for the opportunity, and I will keep information being upgraded as we go along. Thank you.
Thank you, Jim, for all that timely information and valuable information. I'm always amazed at how it continues to change on a weekly basis. So, again, I encourage people to join us at 4 p.m. Eastern Time next week, again on Monday, to learn the latest medical information that you're able to provide. So thank you again, Jim. Next up is our Government Affairs Director, and that's Ken LaSala. I know him and his staff have been working endless hours up on Capitol Hill and also with the White House, keeping in touch with the latest legislation and the latest impact. And so now I will turn it over to you, Ken, to advise those on the webinar of the latest legislative information. Ken, you have the floor.
Thanks, Chief Ludwig. Today, I just have a couple of things. So moving on to the slide there. The first thing I want to bring to your attention, HHS received $100 billion for its emergency preparedness and social services fund. Basically what they've started to do is roll out the first $30 billion of these funds. They put out a press release last week on Friday saying that they were going to start providing payments through the Medicare participating facilities and providers. What we found, though, is that if you're a fire department that has been billing Medicare for transport, you may start to see some of this funding too. Basically, what CMS is doing is they said the $30 billion they received constitutes 6.19% of the overall Medicare FFS payments in 2019. So what they're working to do is provide each entity with a payment that is 6.19% of their total Medicare FFS payments from 2019. So one thing you might want to start doing is taking a look at your accounts that are receiving money from Medicare reimbursements and start seeing a payment start to show up. If you have not seen any funding, you may want to check in with your Medicare administrative coordinator or Medicare administrative contractor and just check in with them and see how the program is going forward. But one thing we want to do is let you know you may start seeing some money from HHS or more specifically CMS over the next week or so. Moving on, also, one of the big issues that everybody's talked about is supply chain issues, the fact that fire departments and EMS departments around the country are not receiving the equipment that they need, gloves, masks, gowns, things like that. We just wanted to let you know we have raised this issue with the U.S. Fire Administration. They are trying to work with FEMA to address this issue. One big issue is the fact that making sure that fire and EMS departments are considered high priorities for receiving this equipment. And that's something which I know the U.S. Fire Administration is trying to address within FEMA. In addition, Chief Ludwig and the IFC are sending a letter to the White House today. In there, we also raised the importance of making sure that equipment that the federal government gives to the states ends up having being considered a high priority for fire departments too. So we just want to recognize that yes, the supply chain issue is a problem, and we are working to get it addressed. The other thing is Congress is working now on their fourth COVID response bill and may get voted on sometime as early as next week. And in there, one of the things that Chief Ludwig is calling for and the IFC will be advocating for is $5 billion each for the Fire and Safer Grant Program, and that's billion with a B. The purpose of that funding is AFG funding to help fire departments pay for all the equipment and supplies that they need, including sanitizers, to protect their staffs while they're out serving their communities. And then the other $5 billion for SAFER is to take care of quarantine expenses, the cost of backfill and overtime, and even to take care of some issues like firefighters having to deal with extra child care costs. So this is something which we're pushing forward. We also continue to push for the repeal of the T-band mandate. Basically, Congress has said that the FCC needs to auction a T-band. We received some notice this week about the importance of the T-band. The FCC actually told New York that it could actually expand its presence on the T-band channels to take care of their communications problems. So, again, it's extra proof the fact that the T-band is important for public safety emergencies like COVID response, and we're urging that Congress repeal the requirement that the FCC auction the T-band spectrum. The final part, too, which we're working on, is some legislation regarding volunteers. We'd like to see the Volunteer Incentive Protection Act extended. This year it's in effect, so volunteer firefighters can receive any type of state and local property tax benefit and up to $600 in other benefits this year without having to pay taxes. And we'd like to see that extended and made permanent, especially since the COVID-19 response has caused a lot of pressure on fire departments, and they're having trouble recruiting and retaining volunteers. The other big issue we have is we're looking at the Volunteer Job Protection Act. Basically, this legislation would allow a volunteer firefighter, if he or she is either deployed to respond to COVID-19, or if he or she ends up being quarantined due to exposure to a COVID-19 case, that firefighter would not lose their job. One of the things we want to do is make sure that volunteers are protected when they're serving their communities. Obviously, the volunteer would have to communicate with their employer, but we definitely want to make sure that if people are out serving their communities, they can make sure that they're not going to lose their jobs. So those are the issues which we're looking on and working on this week, and we look forward to seeing some of this stuff enacted as part of the COVID-4 bill. All right, thanks, Chief Ludwig.
Yeah, quick question, Ken. I hear all the time about the PSOB and death benefits and everything. Can you just briefly talk about that and anything that's changed there at all?
Sure. On our website, you'll see the PSOB office has now issued a new guidance on PSOB cases. What it does is kind of retools the balance. So it puts it more likely that the PSOB office will grant a presumption that if a firefighter was exposed to COVID-19 and unfortunately passed away, that family would be eligible for PSOB benefits. Again, there's a lot of paperwork in there. I do recommend if a fire department can get the Ryan White notification saying that the firefighter was exposed to COVID-19, that will go a long way to helping make the argument that the PSOB office should grant that family those benefits. But yeah, the easiest thing to do is the April PSOB COVID-19 document should be posted on our coronavirus website, and go there, take a look at it, and especially more importantly, hopefully a fire chief will not have to go through those procedures.
All right, thank you, Ken. And then unfortunately, we're seeing deaths in firefighters in Chicago, Detroit. Last night we heard one in Terre Haute, Indiana. I'm sorry about the mispronunciation there. New Jersey firefighter, one in North Carolina, and we continue to receive much more reports of firefighters on ventilators. We pray that there are no more, but again, we want to update those on the PSOB and the availability to that if there is a line of duty death. Next, I'm going to turn it over to a chair of one of our 3 task forces that we have up and running, our latest task force. That is our best practices, our lessons learned task force. And that's turned over, being operated by Chief Tom Jenkins of Rogers, Arkansas. And I asked Tom to please chair that for us. And Tom is a past president of the IFC also, and he was gracious and kind enough to accept that challenge. And so, Tom, thank you for doing that, and thank you for being on this podcast today. Sorry about the mistakes. I'm multitasking. I'm getting texts. I'm looking at emails that people are sending me at the same time, and it's just I need to focus on you, Tom. And so I'm going to turn it over to you, and I'm going to let you talk about your task force and what you're doing.
Thanks, Gary. I appreciate that. I wanted to check my audio real quick. Thumbs up if you can hear me on the videos. Okay, all right. Thanks, Steve. So the best practices task force in particular is looking, I think, to harness what is probably best about our association, and that we know that we have shortages at multiple levels of government. And one of the more interesting elements of this particular disaster is that we've been able to watch it unfold in other communities, and that helps with our level of preparation. And so through using KnowledgeNet, through a dedicated email address that we've parked for this particular effort, what you can expect from the Best Practices and Innovations group is that we're going to work hard to disseminate those things that may fly under the radar. We've got a lot of CDC guidance. We've got a lot of formality with what we need to be doing, but I think what makes the fire service and EMS service so unique is our ingenuity, our ability to adapt and solve problems that sometimes are left undone by other more formal avenues. And so while we're still in our infancy, what we do need is people's participation. You've seen an email blast go out, C19 ideas at IAFC.org, C19 ideas at IAFC.org. And we want people to share things that they've done. And I just think in my own region, in my own city, whether that's, adapting plexiglass to keep patient compartments in ambulances a little bit more viable and separate from the driver's compartment, to just the way that we might be, having to decon PPE that normally we would have thrown away for an acute use. Anything, whether it's complex and innovative or simple and ingenious, we want to try to find that information and then get it out to our members and get it make a difference. And so that's what we've got going. President Ludwig, we're going to continue to work to try to just harness all the good ideas within our association.
That's outstanding, Tom. And I think with the genesis of behind this task force was the fact that we're just all getting bombarded with so much information, and some of it's relevant, some of it isn't, some of it is not a best practice. It's somebody that came up with something. And so what the purpose of Tom's task force is basically to do is sort through this. It's almost like a central intelligence officer sorting through the information and filtering it and putting it down to something that is usable and definable by those in the fire service. So thank you, Tom, and thank you to all those that are serving on that task force, which are many chiefs from all over the United States. So thank you again, Tom.
You're welcome.
Next, I'm going to introduce our other task force member. We have 3 task forces running. One is the Coronavirus Task Force with Chief John Sinclair. You just heard from Chief Tom Jenkins. And our third task force that we have running within the IFC is our Economic Task Force. And there's no doubt that we're all being impacted by this financially. I keep getting reports of budgets being decimated with overtime as they cover for those that are sick or in quarantine, budgets that are depleted buying supplies, and now we worry about the economic downturn. And so I've asked Chief Steve Pegram out of Goshen, Ohio, the fire department there, to chair our Economic Task Force. And again, he has quite a cadre of subject matter experts on his task force, again, to provide us with economic information. And so now I will give the floor over to Chief Steve Pegram. Steve, you have the floor.
Thank you, sir. Just want to check audio is okay.
Yep, you're good.
Okay, great. Well, thanks for having me, and thank you for the appointment, Chief Ludwig. We've been hard at work already. As I've talked to the other task force chairpersons, we really see the COVID-19 task force is working on the incident as it's going on, the response to this pandemic. And the economic is starting to occur already. It was predictable, and we're going to start seeing more and more. So we see our task force ramping up as some of the others may ramp down in the future. the two goals that Chief Ludwig and I decided on very early, number one was to help fire and EMS chiefs be able to access local, state, and especially the federal funds that are being made available. There's a lot of information being pushed out, and we're trying to decipher that, interpret it, and create resources and information for the membership so they can access that money. We're working closely with Ken and the legislative group at IAFC on that as well, and we'll touch on a few of those here in just a second. And then the other one is to be planning ahead and preparing for the economic impact. Here locally, I'm just outside of Cincinnati, Ohio. We've already seen furlough of government employees. One of our neighboring counties recently announced 20% across the board cuts to all budgets as they are seeing the impact of loss of sales tax and income tax. So we implore chiefs to be looking at how you're funded and how that funding is going to be impacted. And there was an article I shared online today with some folks also specific to the volunteer fire service and what's going to occur when those organizations are not able to do fundraising events and other things that they rely on for their funding. So the goal of the Economic Task Force is to keep track of all that, as well as start to provide some resources to fire and EMS chiefs to be better prepared for the economic times ahead. Next slide, please. So already the IAFC did a news bulletin about this. You can find it on the IAFC website, iafc.org. The CARES Act does have money allocated for nonprofit organizations, and a lot of fire and EMS agencies, especially in the volunteer community, may be eligible for some funding through the CARES Act. Again, the information is on the IAFC website. There's money there not only for the organizations, but also Paycheck Protection Program. Many volunteer fire departments have a small cadre of staff that they employ for various purposes. So for the listeners and the people watching this webinar in the future, we encourage you to check out those resources and the potential for low interest loans as well for those organizations to weather the storm through this pandemic. Next slide. Fire service, I think a lot of people have heard about already that there is $100 million earmarked for the AFG, or Assistance to Firefighters Grant Program. We did participate in a conference call last week. The planning is still in the works. The hope is that AFG grant program will be launching a new and separate grant application period, similar to the equipment grants and the SAFER grants and fire prevention grants. This will be a completely separate application specific to the COVID-19 pandemic, and the $100 million is earmarked specifically for personal protective equipment. So it'll be specific to PPE, not trucks, not people, not other equipment, but specifically for PPE for fire and EMS agencies across the country. The FEMA Go application will be the same. It's being updated now for this purpose. So if you are familiar with the AFG program, if you've applied before, you should already have a FEMA Go portal where you can apply for grants. If you have not in the past, I encourage you now to get on to the FEMA website and register for a FEMA Go account so your organization is ready and can apply when that is announced. They're hoping by the end of the month. There's a lot of logistics on getting that program launched and the application ready, but look for that towards the end of March, early April. Again, $100 million earmarked for personal protective equipment. Next slide. Currently, we're working on a survey that will go out to the IAFC membership. I encourage people, once it's launched, to make sure that you take the time to fill out the survey. What the task force wants to do and what we need to do is collect data from fire and EMS agencies across the country, how the pandemic is affecting your budgets, whether that be your current operating budget, your current fiscal year, but also what discussions are being had with your local government on potential cuts, future loss in revenue, and what is your fiscal year 20, 21, 22 budget's going to look like. So we'll be setting up a dashboard on the IAFC website, similar to the dashboard that is currently up, showing the trends of the pandemic and the exposures to fire and EMS personnel. But this will be specific to track the trends that are occurring from an economic standpoint, so that we can track that information and see what impact this is having on fire and EMS departments' budgets. It's going to be important not only for us to prepare and share resources to fire and EMS chiefs, but it's also really important so that as our legislative branch of the IAFC goes and talks to Congress and the Senate and the President and all the different agencies in Washington, D.C., we're able to lobby for the money that fire and EMS organizations as well as local government need to be better prepared and to weather the storm, if you will, from this economic impact that I think we're all feeling already or will soon feel. So look for that survey and dashboard to be launched here in the next week or two. Next slide. I think that was it. I lost track of where I was. So again, working for the fire and EMS chiefs, we're going to continue to gather data, push information out, and encourage you to send any questions you may have to the IFC, and we'll get working on it for you on your behalf. Thank you, Chief.
All right. Well, thank you, Steve. Again, I like your analogy as we continue to transition away from the Coronavirus Task Force and the impact of protecting our people and so forth. The next level of protection is going to come in the form of economic stimulus that's going to be needed. And it's not about saving jobs or preventing jobs, or it's about preparing for the next emergency in our communities and maybe possibly the next pandemic. I was reading the book from the 1918 pandemic, the Great Influenza, and it was interesting to see that virus mutated, and then the second wave was actually more deadlier than the first wave. So anyway, the value that your task force is doing is tremendous, Steve, and all the members on there. I appreciate it all, and on behalf of all the members of the IFC, thank you. Next, I'm going to turn it over to Christina Baxter, Dr. Christina Baxter from Emergency Response Tips. She sits on our Coronavirus Task Force, and I'm going to give her the floor, and Christina now has the floor.
Thanks, Chief. Can you hear me okay?
I can hear you fine.
Perfect. So we'll go to the next slide. And so just for background, I sit on the HAZMAT committee as well as a regular, and that's how I ended up onto the task force. But I wanted to talk just a little bit about where we are and how that relates to the PPE that we use, as well as the disinfection, decontamination processes that we need to be taking into consideration. So one of the things, just to bring forward to everybody's mind, is that we now have enough research data showing us that the virus is transferred as a bioaerosol. Now, good thing to remember is that we still are getting most of our contamination via droplet. The second level would be via touch, and then probably the third would be by the bioaerosols. But where we're looking at 6-foot distances, remember that bioaerosols can go out to 14 feet, 24 feet, and those types of levels. So we do have to keep that in mind. The interesting things to see were that the viral loads that were coming from patients in the ICU were far greater than those in general wards, and that the highest levels that we saw were from patients who were getting oxygen via nasal cannula. So as you start providing oxygen and other materials that will start to provide aerosols, we need to take that into consideration. The biggest areas where we are seeing cross-contamination in all the studies is directly from gloves and from feet. So the footwear was spreading the contamination throughout all of the hospitals. So we need to remember that from a fire and EMS perspective as well, that the bottom of your feet are great carriers for all of this type of thing and need to be taken into consideration. In reality, at this point forward, we shouldn't be wearing those shoes that we respond into the living quarters. But all of this is just to say, as you go back out and look at your risk-based response to an infectious disease, you should be following your airborne isolation precautions. So what does that mean to us if we go to the next slide? I kind of divided these out into each slide, but from a personal protective equipment, if you look and you see all the way out into the fourth column where you see airborne. And when we talked about standard precautions, we just talk about gloves and other things as needed, eye protection, masks, impermeable gowns. But when you get out to airborne, if you follow it across, you'll see that you really want to have gloves that are long enough to interface with your coveralls or your gown, whatever you're wearing, to minimize that skin contact. Not because it's a skin hazard, because it's not. It's really about minimizing the contamination on your garments underneath to ensure that you don't bring that to the next level. It's not available for touch after. When we get to eye protection, we don't have any evidence yet suggesting that it is an ocular threat. However, we don't have any suggesting it's not. So we want to use non-venting goggles for now. The respirator, when you're dealing directly with patients who have either tested positive or are presumptive positive, then we really need to have that N95 respirator or greater. There's nothing saying you can't wear your SCBA, but you do need to think about the decontamination process when you choose that approach. Fluid-resistant gowns, coveralls, or even an NFPA 1999 ensemble, each of those things will provide you that protection you need. You notice we went from impermeable up to fluid-resistant. What we're looking for are things here that pass the body fluid-resistant tests. So we want to make sure that bloodborne pathogens and things of that nature cannot go directly through the gear. So let's go up to the next slide. As we start running out of gear, we start realizing that we're going to have to balance. And the biggest issue we have, knowing that this is an inhalation hazard, is our respiratory protection. So if you look at this table, phase 1 is when supplies are readily available. So that's business as usual. And in that case, our N95 respirators or our P100 canisters, any of those things, once and done, we throw them away after use. Unfortunately, we're already up to phase 2 in most jurisdictions, and if not, phase 3. Phase 2 is when the respirator supplies are low, and we're going to try to extend their use. So in this case, we're going to put a medical mask over our N95. So those homemade masks that you see are great coverings for your N95 to extend its life. We can also start considering using the emergency rule from NIOSH to have APR and PAPR canister interchangeability, meaning if you have a Scott APR and you only have MSA canisters available, you can use those interchangeably. Just make sure you inspect it well before you do anything else there. And this is where we start prioritizing who has what level of protection. As Dr. Augustine talked about, having that one person who goes forward and starts to get more information, that person who goes forward or that paramedic who is working the patient, they need to have that highest level of protection. But what we need to do is figure out ways to minimize the contamination to others. So that way we can have lower levels of protection to the other responders and maybe only have one person up front with the highest level. When we get to the phase 3, which many agencies are already at, that's when our respirator supplies are depleted. This is one of the areas where we start considering the reuse of single-use protective equipment. So remember, when NIOSH certifies an N95 respirator, it's certified for one per time. You're putting it on, you're taking it off, you're throwing it away. That's how it's certified, that's how it's tested. As we start getting into the need to reuse these, we have to think about the implications here. So all of the different tests that have been done on these are mainly about influenzas. So when we start talking about this, you'll see in all the different things and asterisks and everywhere in parentheses, maintain the individual user of the mask. The reason behind that is that a lot of these test methods have only been tested against what I call our wimpy viruses, like influenzas, coronaviruses. These things are easy to destroy. But what if somebody has a hepatitis virus? Also easy to destroy. What if somebody has MRSA or somebody has a contamination with C. diff? Those aren't as easy to destroy. And that's where we need to take into consideration the type of disinfection that we do and ensure that we aren't spreading other diseases by sharing equipment. And that's the main reason that we really need to think about this. As we start to reuse equipment, make sure you're looking at it from the bigger picture. Don't just focus in on the COVID-19 virus, because we know that's easy to destroy. Another thing to remember as we decontaminate and reuse our respiratory protection, N95 filters, almost all of them throughout the world, use a middle layer that's called an electret. That electret just means that there's an electrical charge on the fibers within that inner layer of the mask. So you cannot put that in a plastic material afterwards to store if that plastic material has electrostatic charge, because you could pull the electrostatic charge off of your filter. That's why it says all the time to store in paper bags or in boxes, because we know that those are not going to transmit an electrical charge and pull the filtering capacity off of the filter. So if you were to store it in, say, a Ziploc bag, that can pull all of your charge off of the fibers within the N95 and, in essence, make your N95 more of an N80, okay? So the N95 and that electret filter is what gives us the capability to pull the virus particles out. So we have to be very careful. Now, different if you're using a canister. So a P100 canister or cartridge, take that off, store it separate from your mask, disinfect your mask as you always would, wipe down, do not spray the outside of your P100 or canister, and you can store that in plastic or other things. It doesn't use an electric filter, so there's no issues there. So let's go to the next slide. And we're going to talk here about the EMS escalation. So in this consideration, when we start talking about standard precautions, which I tongue-in-cheek call the not-so-standard precautions, because as we can see with the transfer of contamination from person to person on feet and on gloves, that maybe we're not following our standard precautions as well as we should be. But what we should always consider is assessing the patient from at least 6 feet if possible. So if you can't get that patient is not capable of coming outside and they're not capable of wearing a mask, then let's consider starting to ask those questions from the family member or the patient from as far away as we can, maybe the next doorway. Okay? If the patient can sustain a mask, provide it with them. If they can't sustain a mask, maybe consider putting something like a face shield on them instead, where they can try to minimize that spread of their sputum. Okay? Adjust all those precautions as necessary, but as you start coming up, as we get to a contact hazard, we always start adding in plastic layers, because contact could be something like C. diff. We surely don't want that in our ambulances. So that's when we put plastic between the patient and the stretcher. Make sure that if they are having any GI illness, that we kind of put one over them too, if possible, remembering that depending upon temperature and time in transit, a lot of the patients will not be able to withstand a plastic covering as well. As we start getting up to droplet, we're going to consider isolating the department. I heard somebody talk about today earlier about using plexiglass just as a fitting to maybe keep a separation between that driver compartment and that patient care compartment. It's an absolutely excellent idea of ways to do it. If you can, increase the ventilation in the patient compartment. But as we get up to airborne, we've got to start considering all of these things together, and also keeping in mind that that airborne virus now can get into the ventilation system. So it's not patient compartment and driver compartment. It's all one compartment now. And if we don't have an isolation in place in advance, then that driver may need to wear an N95 just to drive. So if we go on to the next one, we'll talk about disinfection. Okay, here we have to talk about, everybody should be very well aware of the standard. We're going to wash our hands. We've got 20 seconds of contact. We're going to clean surfaces. We're going to try to use EPA registered materials to do that. Remember, EPA List N is a recommended list of materials that should be suitable for the COVID-19 virus. The issue that you're going to have is none of them have been tested against it. That's just a should be based upon past scientific data. You can ask vendors if they have real data on the virus, because there are test agencies doing that testing now. As we start coming forward up to droplet, we have to start thinking about our PPE and having cross-contamination there. As we get to airborne, where we're going to be dealing, we have to remember that that PPE becomes an area where materials are then transferred. There was one paper that was recently published that showed that one of the highest areas in the hospital where contamination was occurring was where the medical staff were doffing their PPE. So as they were taking off their gowns and overgarments that they were wearing with the patient in that area, they were getting more contamination going just by taking it off. So let's remember back to those best practices from Ebola and make sure that as you're taking off your gear, you're being careful about it. And one thing just to bring in mind, if you haven't paid attention to the fact that a lot of people are actually wearing their turnout gear on these calls, either because they went on the call and there was nothing in place saying that it was a COVID-19 call, or they're on the call and all they have for extra protection is their turnout gear. In these cases, we want to try to minimize the chance of doing preliminary exposure reduction in the field because these are dry particles, and if they have dried off, they'll go airborne. So at the most you would want to do in a field operation would be to mist it lightly, not directly at it, but above it, and let the mist fall down to increase the weight, put it back into a water matrix, and hold it in place. Best case scenario, just take off your gear, bag it, send it back to have its proper washing and extraction via NFPA 1851, which is the selection, care, and maintenance for turnout gear. So if we go to the next one, okay, a lot of people ask me and continuously, what disinfectant is going to work? Well, the really good news is if you look to the right on the chart, you'll see that lipid enveloped viruses are the easiest to destroy. Thankfully, that's where we are. So we are in a lipid enveloped virus when we're talking about SARS, coronavirus 2, or the COVID-19 disease. So very easy to destroy. So most disinfectants will actually do a pretty good job. But if you are trying to develop a capability that is going to be for your department for the long term, the other things that may come in. Remember that in all the different tests that we've done on fire departments over the years, the two major things that were showing up in departments were C. diff and MRSA. And those are the things that we also need to destroy. The problem we have is as you come up and see up here to spores, C. diff is one of our hardest materials to destroy. So if I'm selecting a disinfectant and I want it to be an enduring capability for my department, I generally look for a disinfectant that has C. diff capabilities because that means that all these other things below it, it's very likely to also destroy. So I want to pick a broad spectrum material. I want to make sure that the pH of the material and any of the chemical reactivity of the material can be used on clothing and other sensitive equipment so that we don't destroy everything we touch. Make sure it's a low odor. If not, you want to make sure that the ambulance is properly vented or the apparatus or the living quarters prior to reinhabitation. Multi-year shelf life, so things that come as a dry material and then you reconstitute, they're great for us because then we can leave them there for years and not have them expire. But we want to make sure they're easy to mix. And then the biggest thing we've had lately is affordability and availability. Almost all of the things that we usually rely upon for all of our decontamination capabilities are out of stock. We're looking at June for resupply. So what I like to do is go to that EPA List N, find out what materials are most likely to destroy the virus, and then go across and say, okay, what else is on the market that produces the same material? I can make it the same quantities with an active ingredient. And if you have questions on that, please reach out. Let's go to the next one. Okay, the last topic I'm going to talk about really quickly is just the NIOSH N95s. So we have a problem today in the United States where we do not have enough NIOSH certified or approved N95 respirators. So on March 24th, the FDA released an emergency use authorization allowing us to use respirators that came from different countries. So what I put here is just a chart of the N95 in the US in the first or second column, followed by the European Union FFP2, followed by the Chinese KN95, the Australia New Zealand P2, the Korea First Class, Japan's DS, and then Mexico's N95. What you'll see is if you're looking for the level of protection that is most like what you are used to, the KN95 from China and the Mexico N95 follow almost in line with what the U.S. government uses. The problem we're having right now is that almost every one of the systems that I evaluated today for different agencies were counterfeits. And so we have a huge problem with counterfeit masks being on the marketplace. So let's go to the next slide real quick. So this is just what you should look for. If you have a product that tells you they're NIOSH approved, that makes it really simple. There's a couple of things. If you look at that mask in the middle, you'll see either NIOSH written out or you'll see the NIOSH logo. You'll see the name of the approval holder. So a lot of the ones you see in the US, 3M. So where it says manufacturer's name, it would just say 3M. Okay, the TC number. That is the number for this testing and certification approval from NIOSH. That's a number you can look up. Filter designation, is it an N, an R, a P, meaning is it not for oils? Is it going to repel some oils, or is it oil proof? Then the 95, 99, 100. It takes out 95% of the particles, 99%, or 99.97%. And then, of course, you'll see the model number. One other thing that a lot of them will have is the lot number. That's really handy for us to have because we can look up and find out if everything matches. So one thing I put up here was the NIOSH Certified Equipment List website address. So you'll see this as you go back through the slides later. But if you go to that address, you'll see TC approval number. So if you just start off, it's going to be TC, it'll be 84A for a particulate respirator, and then there'll be a number after that. Type that in and say view results. That will let you see quickly everything that's certified to that number. And so even if it's somebody's off-label of the same mask, it's going to show up. And so that's the quickest and easiest way for you to certify that this is a NIOSH approved. Now, what if it's not NIOSH approved? What if it's from one of our partner countries? That starts getting a little bit different. So I'm just going to show you one example because if I went through every one, it would be monotonous, and we will later publish these on the website. So let's go to the next slide. This is just if it's an Australia, New Zealand P2. So every country has different ways that you search. So in NIOSH terms, you always look for that NIOSH trademark logo. But if you're in Australia and New Zealand, if you look at the top right of this slide, they have what's called the 5 mark list. So certified product with the 5 marks. If it is a certified product, it's the first thing I'm looking for. Is that marker there? Then I'm going to go to the SAI global website. And when I look there, I can type in the license number I'm seeing on their documentation, the company name, the model name, any of those things, and I can say, show me the products. And then I can start clicking and going in and finding the exact products of interest and end up all the way down on the bottom right where I have a list of the model number, the face piece, covering type, the filter cartridge, all of those different things. And when I look at it as a whole, now I know that this is likely a true product. And the problem comes in that as you get harder and harder between different countries to determine which ones are which. So we're hoping in the next day or two, we'll have charts made like this for every single one of the partner agencies so that you can start looking to make sure that as you start evaluating a product, that you have the comfort that that product is actually certified and is not one of the counterfeits. And Chief Ludwig, that was all I had, so I'll turn it back over to you. Thank you for the opportunity.
No, thank you, Christina. That was wonderful. Very valuable information. And it's interesting you brought up the fake respirators. I was actually able to go to the CDC's website, and they also have a fake respirator page also. Besides the certified page that you mentioned, they also have a fake certified page, I'm sorry, not a fake certified, but a fake page of respirators. And I was just totally astounded at the number that are out there. Are you familiar with that page?
Oh, yes, sir. I actually used that page today for one very large federal agency was getting ready to procure one of the masks that was on that page today. So NIOSH NPPTL, if you're not familiar with the National Personal Protective Technology Laboratory, is a phenomenal government agency. And they are there. If you have questions, just reach out through that link, and they will help you start looking at all of this. I call on them repeatedly throughout this process, and they have been nothing short of extraordinarily helpful.
Yeah, I found it by simply just Googling CDC fake respirators, and it's an entire page full of stuff that comes from various countries that is fake, and it just was astounding. So you think we're protecting our people, and we're giving them something that's actually exposing them. So
Yes.
But thank you, Christina, for being on here today, and I want to thank all our panelists today who provided just outstanding, terrific information. I also want to thank Chief Sinclair, Chief Pegram, and Chief Jenkins, who all are chairing our different task forces. Finally, I want to thank our interim CEO, Rob Brown of the IAFC, and all the members of the staff of the IAFC who are working very long hours and even weekends. For all those who are listening today, if you have any questions, please email covid19tf@iafc.org. As a reminder, we will be doing these webinars every Monday at 4 p.m. Eastern Standard Time. And we will also, again, in the information in the future, will include economic information and from our best practices, anything that we think is relevant that you need to know in a timely fashion. So in order to attend those webinars in the future, please register at iafc.org. Again, I am honored to serve in this noble profession with so many outstanding people who make a difference in their communities every day. Please join us again next week as we provide the latest updates and vital information. In the meantime, everyone, please stay safe. God bless you, and may God bless the United States of America.